Good afternoon, everyone, and you're all very welcome to today's webinar brought to you by the HSE, Time to Get Moving Again. So before I hand you over to your host, a few housekeeping notes before we start. You are all muted and videos are off, so you will be viewing the presenters as each one presents. We do have some interactive features here turned on today. We have the Q&A button, and that's located at the bottom of your screen. So please feel free to ask any questions there as the presenters are all backstage and waiting to answer. This webinar is being recorded, so the slides and the recording will be made available at a later date. And if you experience any audio difficulties, if you can't hear us, just click join audio on your device or your laptop, or else join the meeting by dial-in. So without further ado, I'm going to hand you over to your host, Dr. Siobhan Connelly.
Thanks, Leo, and delighted to welcome you all here today. We've a tremendous assembly of speakers, as you'll see from the list, to really set the scene in what I think is a really a time of great hope after a time of great challenge. I'm going to introduce each of the speakers as they're coming through, and I'll be joined by my colleague, Dr. Mike O'Connor, in the afternoon, co-chairing the event. Very much, I suppose, the afternoon is set out around describing what has been the big challenge, I think, for many older people in respect of the impact of cocooning. But also setting out how it is that we are going to actually, through health and social care services, support people who are emerging from cocooning and maybe facing particular challenges, and then lead that into a discussion around the launch of the National Frailty Education Programme. So without further ado, I'm going to share my own talk here, and we will okay. So again, as a National Clinical Advisor and Group Lead for Older Persons, along with many of you who are here on the programme, we have been aware of, I suppose, the very significant challenges that cocooning has posed, which were put in place around the 15th of March. My apologies, my slides have frozen there, Leo. Great. So, you know, this, I suppose, what has happened is that we've had a good opportunity just now to really reflect on the road that we have been on, as I've said, in terms of the pandemic, which really has been a most daunting year. And just if we look at the, you know, newspaper headlines that we were facing just this day last year, where we were still very much in the throes of lockdown. We were still being advised that it was too early to lift restrictions. We were still dealing with, you know, very significant levels of death, particularly within our residential care facilities, but also across a number of populations. And if we reflect on where we were then with where we are today, which reflects an entirely different story in the context of a successful national vaccination program that is really, I suppose, enabling a very strong momentum to towards, you know, emerging from lockdown, and particularly in terms of emerging from cocooning because of the vaccination impact in our older population. And why has it been such a huge piece for our older population that we've been able to do that? Because, as we know, they have carried the greater burden of risk in respect of COVID-19, both in terms of hospitalisation, severe illness and mortality. And we know that over 90% of the deaths related to COVID took place in our population over 65. And so for those of, you know, for colleagues who, from a public health point of view, who were trying to develop strategies that would mitigate the impact of COVID-19 on those older populations by reducing new cases and reducing mortality, it was always a case of how would we manage successfully to control this dreadful virus and pandemic in these older populations, while minimizing, if you like, the adverse consequences of cocooning that we knew from a very early stage we were beginning to see in people in terms of loneliness and isolation, particular impact in terms of the reduction in services and the decline in physical and cognitive function. And within that, then, I suppose from a services point of view, we wanted to examine more closely what the impact of cocooning was in respect of older people. And this report was published online by the HSE in January 2020 and really pulls together those strands of information that are coming through in respect of the impact of cocooning itself, but also the measures that were taken to try and support people as they lived these very restricted and isolated lives, and also then looking again at the impact on service utilisation. So with that in mind, I think always once again worth coming back to the enormous contribution made by made by us as we age in Irish society, as highlighted frequently by Tilda and other colleagues, and the huge contribution made in respect of very crucial aspects of life, including providing for spouses and other family members in terms of care, grandchildren, and the significant proportion of efforts that goes into voluntary activity. Likewise, I think when we're speaking to this, it's very important to be mindful of the, I suppose, specific challenges faced by many who are living alone as they age. And within that, I think, the measures that were drawn up to try and mitigate the impact of cocooning were very widespread and were largely successful in respect of the fact that they were able to harness, responses across local authority, third sector NGOs, and pivot, I think, some of the crucial health services around how they would best support people who were very vulnerable or isolated in respect of cocooning. And my colleague Sarah McCormick is going to speak to that in more detail. Efforts, I think, of voluntary agencies and just local communities in supporting people who were cocooning, as evidenced through, for example, partnerships with GAA and others, really became clear to us in the context of that response. But even with the totality of the responses that people were putting in place to support older people who were restricting and isolated at that time, it's clear that we are seeing a significant level of impact, as I've said, across a number of areas. What's been very much spoken about is the sense of social isolation and loneliness that people have been experiencing, and we know that that's actually been captured very well in studies by Tilda and Alone, for example, such as this one published in 2020, where callers to Alone services at that time were reporting a very significant rise in reporting negative emotions, and were requesting specific supports for physical health, mental health, and other issues. And we know that those supports are linked. Those impacts then are linked to physical health impacts in terms of heart disease, stroke, increased harmful use of alcohol and tobacco, and other impacts, which we will focus on in the rest of the presentations here. But there are actual cocooning health effects now that we can actually name, and I think part, I suppose, of what we're actually beginning to kind of acknowledge is a broader, what we would call, deconditioning pandemic that we feel many services will be facing as a result of the pandemic itself. And I think one of, as clinicians, and many of you I know who are joining the call are aware of, one of the significant impacts has been on the way people use services in particular. And, initially, this time last year, we faced a dramatic reduction in ED presentations across all age groups, with about a 30% reduction in emergency attendances by older people. That seemed to recover somewhat over the summer, but we are aware that it has, had impacts then in other ways. So, for example, we know that within the Tilda studies that we've been looking at, that roughly 27% to nearly a third of people have reported delaying their access to medical care as a result of the pandemic itself. So I think we're going to see more. We're going to see more of this as time comes on, and what the impact of that is actually going to look like. My apologies, my slides have just frozen there for a moment. The type of appointments that have been delayed include, for example, routine access to GP and dental care for some, but we actually know that for a huge group of people, then the lack of access to day services, the lack of access to respite, the lack of access to services that support carers and others has been a major burden over the course of the pandemic. Equally, people are reporting less physical activity, maybe a small increase in walking, but not across the board. And more particularly, they're reporting, older people are reporting a significant increase in sedentary activities over the course of the cocooning period. I think this report from Family Carers Ireland highlights very nicely, I think, the significant increase in carer burden that has been experienced by many family carers. And within this report, you know, their key concerns were about not being able to access care and supports for either themselves or their loved one, and particularly as well as the decline in their loved one, being able to manage the changes, particularly in relation to dementia and other chronic illnesses in terms of overall decline. So the report itself set out a number of recommendations to try and support people within the, I suppose, period of cocooning that we were still going through at that time, because many of these were made towards the end of last year. And they really focused on what the advice around cocooning and messaging around same would look like, the need to mitigate, I suppose, some of that impact by encouraging those of us who could to engage more in outdoor activities, and encouraging, I suppose, increased use of our social bubbles for support, looking then, I think, at the specific kind of pandemic impact in terms of the nursing home sector, and particularly around the impact of visiting restrictions and how they could be better addressed. And you can clearly see what the recommendations in the report at that time were. But obviously, you know, since then we had the surge as it came back in January, and that we're only beginning to emerge from now. But I think aligned with that surge, as it was happening, was that beacon of hope around what the COVID-19 vaccination rollout would offer us. And almost immediately we could see within our long-term care sector, the residential care sector, the huge impact that the vaccination programme was having, and likewise amongst our healthcare workers. And so we do have a huge amount of confidence now that we are in the space of, I suppose, having successfully rolled this out into our over 70s and other older people as they emerge, you know, that there can be great confidence about, I suppose, our ability to re-engage in society and to emerge from this very, very difficult period. We're now in the place, as many of you will have heard, that 30% of adults in Ireland have now received their last vaccine, their first vaccine dose, and we're looking at the lifting of some of these restrictions, at least from Monday. So we have lots of reasons for hope, and I suppose the point of the webinar today is really to kind of set out how we are going to support older people and others as they emerge from this cocooning experience, how we support many of the older people who are still living in our communities, recovering from COVID, and then look at what, you know, and this initial focus, particularly in terms of supporting physical activity and nutrition might look like, while at the same time acknowledging that it will take, I think, some time for some of the kind of significant burden around psychological supports to be acknowledged and recognised. With that in mind, I would like to actually, on a really positive note, invite you to participate in a short poll that we have drawn up for all of the attendants on the call around, you know, if you could tell us what you're most looking forward to as restrictions lift, and maybe then as we come towards a short break later in the afternoon, we'll be able to share the results of that poll with you. In the meantime, I'm going to introduce our next speaker, who is May McConnell, who is our patient champion from the Integrated Care Programme for older people in Sligo. May very kindly shared her thoughts with us in respect of her impact of the impact for her of what the last year has been and her experience around same. And I think it'll reflect for those of you who are attending, both as older people themselves who've been through this experience, or possibly carers, or indeed the many frontline health professions that I know are on this call. I think it'll reflect for you, I think, a lot of the experiences that you've either lived firsthand or that we have certainly experienced firsthand on the clinical front line in terms of what older people themselves have been telling us. So I look forward to sharing that experience with you, and we'll introduce our other speakers after that.
Hello, I'm May. Just like to talk about the first lockdown. I thought the first lockdown was just going to be for a short while, a couple of months. So there's a novelty factor. Cleaned out all my cupboards, cleaned out the attic, sorted out music. Was very good going for my walk around the garden. I had the garden grass all ploughed down flat. But then after a while I realised this wasn't going to end quickly. Things weren't getting sorted. And then I think it became real. Couldn't see my friends except on Zoom, which I have learned to hate. I never thought I'd be involved in technology, but I learned how to use it. But now all I want is another human being. I feel very concerned for my own age group, because I suppose I'm lucky enough, even though I hate Zoom, that I can use it. And I have various bits of technology that I can use, but a lot of my friends haven't got that. And they're very cut off, so there's no chat. And that's what most people, I'm involved with Active Retirement Ireland, and that's what most people miss more than anything else, is just the chat and the cup of tea, the human contact. So Zoom is not going to be the same. I find using the phone, just the ordinary phone call, that helps. It's a little bit more real, I think, than Zoom. But it's the freedom, it's the lack of freedom. Freedom has been taken away from all of us. It's not that we would go somewhere interesting every day or have something interesting to do every day, but just to know that I could, if I wanted to. I could get into my car, I could drive over to the beach, I could maybe ring somebody and say, would you like to meet for a coffee? But that was taken away during the first lockdown. The second one, we all realised that it was much more serious, and the novelty factor was gone, and we just had to learn how to live within our own space, do all the right things. I suppose in lots of ways, my age group are lucky. We grew up obeying rules and regulations. So that helped a bit. But I think, well, speaking personally, I'm not as strong as I like to pretend I am. Initially, I was fine. What are all these people talking about, being stressed, etc., etc.? But the second lockdown, I definitely did feel it. And the great thing was, as soon as I admitted that I was stressed, and I didn't like this thing, and it was awful, and it had taken away all the things I loved, I felt a bit better just to be able to do that. And just to go back a little bit on some of the main events that I've missed out on. There was a wedding, my next door neighbour's wedding. And that would have been a lovely gathering, because it would have been all the neighbours apart from their own family. But it would have been a gathering of neighbours, and that would have been very special. Then my second grandson, Connor, he was commissioned there a couple of weeks ago, and that would have been a spectacular event, from what I hear anyway, that the army do it really, really well. And I would love to have been there for that, because it would remind me of his mother's graduation when she became a teacher. And my father was able to go to that and what it meant to him. And we have lovely photographs with him wearing her hat, etc. And that would have been lovely, but that was gone. And then a sad event. My aunt, the last of my father's family of 17 children, the last of her tribe, she died 4 weeks ago in her 97th year. And because she and I were fairly close in age, she was like the big sister I never had. And we were very, very close. And thank goodness I saw her before Christmas, which was great. But I really wanted to be there, even though I knew I wouldn't be able to go into the church as such. I didn't want to see her in the coffin, because I wanted to remember her as she was, full of life, living on her own, right to the end. I wanted to remember her like that. But I couldn't go. I wasn't allowed to go to the funeral. I was going to break all the rules in the book. I had decided I was going, and that was it. But my family, my children, became the parents. And they said, look, Mum, you really know you can't go. And I had to give in. I knew I couldn't go. But I was heartbroken, because I just wanted to be there to see her off on her final journey. So there were 3 events that I just felt there's no way we can play back events like that. They're gone, they're over, and that's it. And where do we go from here? I've been thinking about this quite a bit recently, and I realised this is not going to finish. It's not going to end in the near future. In 6 months' time, in 12 months' time, we're going to have to learn to live alongside this pandemic. And we're going to have some sort of life, a real life. In fact, just recently, my local active retirement group, we had a Zoom meeting just to think about ways and means that we could re-emerge into real life. And one of the things we're going to try to do is just to ring somebody, a member of our group, just say, I'm thinking of going out to Strandhill for a walk. I'll be there at 11 o'clock. Do you fancy meeting? And maybe we can get a cup of takeaway coffee. So we're going to have to do it very gently to let people practice being back in society and to try and banish the fear, because there is a lot of fear out there. I know that from talking to my own age group. But if we're going to have to live with this, we're going to have to find ways and means, new ways and means of doing it. And just baby steps, I suppose, to begin with. And then maybe when everybody is vaccinated and safe, and we might be able to meet in maybe a bigger group, 5 or 6 people, and just go on from there. Because otherwise, my age group are just going to wither away, and that would be extremely sad. So I'm hoping, and we talk about all the different age groups that have missed out, and I don't like the idea of pitting one age group against another, because that's not fair. We all have missed out, and we've missed out in different ways. And instead of blaming each other, I think if we just try to be a little bit more positive and do what we can to make it a better life in the future. And that's what I hope most of all, that the beautiful things that have happened during lockdown, where people looked after each other, people you didn't expect became concerned about you, became your friend. My local postwoman who put a little chocolate cockadoodle on the top of my postbox at Easter. You know, those kind of small things. She'd ring on the door, "Are you okay, May?" People, this great kindness that probably was always there, but we were all so busy that we kind of, and we didn't want to interfere in people's lives. That was the big thing, you know, you can't be nosy, you can't be interfering. But this gave us permission. We really needed to know if people were okay. So I genuinely hope that we bring that with us, because we'll have a much richer world if we do. And we'll get there. We will. We'll get there.
I think you'll all agree that's been a really powerful presentation, I think, for May. And I just want to thank her again. She's not here on the panel today, but I think, May, you've really kind of highlighted and put in perspective for us what this should all be about now. I'd like to introduce you next to Sarah McCormack, who's had many years of working with us in the HSE. She's currently a member of the HSE Health and Wellbeing team and is the National Programme Lead for the implementation of Healthy Ireland in the Health and Wellbeing COVID support group for older persons. And she's going to talk to us about the supports that have been put in place, many of which are still ongoing and will be there as people continue to, I suppose, come through this pandemic. Thanks, Sarah.
Thank you very much, Siobhan, and good afternoon to you all. And I must say it's a great privilege for me to be following May, that wonderful lady who told her story there. And indeed, it is actually so appropriate because, May, I want to call out to you there, and I think that you're watching here. You are the living example of the achievement of the vision for Healthy Ireland and the Healthy Ireland framework, where every individual can enjoy physical and mental health to their full potential. So good luck to you and long may it continue. And today, as Siobhan has said, I'm talking to you in the context of supports for the older persons, health and wellbeing supports, and they all come in the context in relation to Healthy Ireland. So Healthy Ireland, the Healthy Ireland framework was launched by government in 2013 and has taken us up into 2025. So as you can see, it's a long journey that we're on. And that framework is the National Strategy for Health and Wellbeing, and it is a movement across the country. And that movement across the country there is bringing everybody together so that they can actually improve their health and well-being. And what is driving it? It is the drive in relation to chronic disease. So we know that 49% of the people over the age of 50 have at least one chronic disease, and 15% have more. And those chronic diseases is rising at a rate of 4% per annum for diabetes, cardiovascular, and respiratory disease. And we know the impact that mental health challenges are having on us through stress, anxiety, and depression. And look at there's 41 million people that actually die each year from chronic disease. But the real take-home message here is that chronic disease is largely preventable. And it's largely preventable now because with the move on of the science and the research, the attributable known preventable risk factors are there. So if you look at 80% in relation to coronary heart disease, 65% for cardiovascular, and 73% of COPD, we know the risk factors. If we address and manage these risk factors, we can greatly reduce the risk of we actually having a chronic disease. What are these risk factors? These risk factors, there's nothing new to say, there is no big silver bullet here, but it is about smoking, alcohol misuse, what we eat, how healthy is our diet, what's the level of activity that's there in our lives, and how we actually look after our mental health. Overweight and obesity, and the combination of all of these factors that are coming together, and recognizing that the environment we live in has a huge part to play in relation to our health. And now in the 21st century, this is really where we are now looking at what has now become known as lifestyle medicine. And lifestyle medicine is very complex because of the fact that it is all of those factors. So we may look at somebody and we may actually say, oh, like I'm overweight, but the consequences and the reasons as to why that I'm finding it challenging to manage my weight can be very much multifaceted. And Siobhan said there earlier in the presentation is that very often you can actually see physical ailments that are actually coming from in relation to the backdrop of in relation to mental health and mental challenges that are there. In the HSE, we have got a team of National Policy Priority Programme leads and also National Dietetic Lead who is actually supporting the work there from Healthy Ireland, looking at the research, evidence-based programmes, policies, campaigns, websites, all working hand in hand with the government's Healthy Ireland framework implementation. And this part of here in relation to dealing with chronic disease, it is all about a life course. It's starting right from the very beginning, working up in relation to as we grow into those golden years and enjoying our positive older age. And it is that piece of lifestyle behaviour change. And it's been recognised more and more now that as many people are presenting to GPs and to the medical professions, is that the solution to their ailments is not in what we know as the traditional prescription, but is sometimes referred to there as the green prescription and into social prescribing. And social prescribing framework will be launched in June. I'm sharing with you here some of the information from the Healthy Ireland survey, which is carried out each year. So just to show you, and well, being aware there, is that as we go into our older years, that the quality of our health actually starts to deteriorate. So if you look at that change, 45 to 54, 85% say their health is good. But if you look at there into 75 years plus, we're gone down to 60 to 64%. Another interesting piece here from the Healthy Ireland survey is health conditions. So if you look right there at high blood pressure, so if we're in that category of the 45 to 54, we're running there 15% in the male category, but right up there 39% as soon as we hit in relation to the 75 years. If you look at arthritis there, look 45 to 54, it's just 4%, right there gone to 33% as soon as we get to the 75 age group. And I just pulled in there for you looking today in relation to about being moved and getting on the move again, is that if you look at here, there's only just 18%, 75 years and older, that's actually achieving the recommended 30 minutes a day of activity into their lives. And of course, as I talk about of this, is that our lifestyle is very much impacted on what we do by what happens in our life. And look at what COVID actually did to us there, rise in alcohol, tobacco, junk food, and sedentary lifestyle in relation to watching TV. So taking all of this into the context in relation to the older persons and health and wellbeing supports, and Siobhan mentioned there in relation to the report that was produced there, the impact of cocooning. And it was on the back of that is that the HSE recognised there in relation to saying we need to do more and we need to take a more focused approach on our older persons looking at their health and wellbeing. And out of that, a working group was established, co-chaired there by Siobhan and myself. And we agreed there to take a dedicated project manager from Age Friendly Ireland to work with us in this project, to build on the knowledge that was already out there and the connections that were there across each county. And the scope and the way that we actually worked and looked at the work that we were going to do is that it was grounded on the government's Healthy Ireland Keep Well campaign. So what is that campaign that was taking place and is still continuing to take place? And this campaign is for all of the population. And we, of course, were focusing particularly in here at the vulnerable older person. So keeping active, staying connected, switching off, eating well, and managing your mood. So government invested and put money into at each county level of supporting these activities and identified national leads that would lead out on those. And indeed, when you heard May talk there, many of those will resonate with you, how important that it actually was for you. Within the working group and the work that we're actually doing and looking about health and wellbeing supports for the older persons, we're following a plan in relation to this. So the first thing we're doing there is doing a data gathering exercises, linking in with the Age Friendly Ireland programme managers that are out there in each of the counties. We are analysing that data and grouping it, and at the same time it's going on a database inventory there in Age Friendly Ireland that will be available as we go into the future. We're then engaging as part of the process along the line for each of the theme areas with the HSE National Policy Priority Programme leads and taking their expert advice. We then link back to the working group. We then consult with the Older Persons Executive Council. We hold information awareness session on these topics with the Age Friendly Ireland programme managers and Healthy City and County coordinators. And we report back to the working group and agree what should be the next actions and decisions to be taken. So where are we in relation to each of these thematic areas? So from eating well, we have all the stages gone through, and we have identified, and we are creating some additional resources there to identify some gaps that we identified. Alcohol, the same thing, and we'll show you some of the information that we're developing there in it. Active living, we presented the findings for the active living and the physical activity to the working group, and I'm sharing with you some of the recommendations from that today, in particular because of the focus on being moving. And the other areas we're working through, we have done some developments in relation to mental health and well-being, and Minding Your Wellbeing, which is a resource that's available to everybody out there. A suite of 5 videos is there for supporting everybody in relation to their well-being, and we are working across each of the other areas. Resources for the older person, we looked at these and said about from an eating well perspective. So resources for the people that are looking after the older persons, and also resources there for the older person themselves. So just highlighting one of the ones that was there was about the food parcels. We know that during COVID, loads of food parcels were issued out, but what was absolutely important was what's in the food parcels and ensuring that what was going out to the people was appropriate and to ensure that it was nutritional for them. Other ones, when we consulted with our older persons, was key things was really valuable to them was about the store cupboard ideas, also being able to get tips for what they could actually eat, and being able to build on the nutritional side. And we learned from that we would actually do a reprint of a really valuable resource that's there in the HSE in relation to that, and we're going to print that 101 square meals and make that available out across all the counties. From the alcohol perspective, and this was really interesting because I was one of the persons going to the older persons executive council, and I thought, my God, what would they say to Sarah talking about reducing my alcohol? But that was not the case. They really realized that more information was needed in relation to alcohol and the older person, and we have produced a new leaflet there which will be going out across all of the counties, telling people, just giving them hints and tips about alcohol and their life. So I'm sharing with you now some of the observations and recommendations that we have there in relation to physical activity and the older person. So the first thing is that there are many resources available. Indeed, for physical activity, there's an enormous amount of resources available, but there's a lot of duplication that's there. We also need to look at how we actually enhance our communication of those resources being available and the support networks that's there into them. The move to online is certainly one of the ones that's challenging, and may refer to that because many people are actually being excluded because of the fact in relation to the move to online. What's also important here is to consult with the older person as well. There's a need to reach out to older people that are isolated and that are living alone. We need to know where they are, who they are, and what will work for them. You know, the one thing does not fit everybody. Smaller counties don't have many resources, and therefore it's important to actually look to see how do we actually leverage this across the country. Organisations that are there, Sport Ireland, Sleep Blue and Xwell, we need to agree those initiatives and the outcomes and how we actually measure them, and to ensure that we're building the functionality across their in relation to people. Social prescribing, as I've mentioned, wonderful opportunities there to come and think about how we actually will have the referrals there for the older person. There's also great opportunities there for us to build on for the older person, because right now in each of the counties, all of the local authorities are developing their next 6-year local economic community development plans, and we need to work with them and ensure that the older person is right at the heart of what is being provided for them. So as I conclude to you here today, it's not just about movement. It is not just about getting people and looking about what physical activity we can get for them. It is really important to look at the holistic person, that lifestyle medicine approach, because it is all of these factors and risk factors that actually impact their life and make it the challenge for them to enjoy life to their full potential. And as part of that, and as part of our physical activity movements that's there, we're actually taking a new program called Get Up, Get Dressed, Get Moving, which will be available to everybody across the system there. So I'm leaving you with some links there to some key resources that you can actually access and have for yourself. So thank you very much.
Super, Sarah. Thank you so much. And again, just to re-emphasize to people that all of these presentations with these resources will be available online after the talk on the HSE website. It may be next week before we'll have that there, and we'll message you accordingly. And the presentations will all be made available to attendees as well. I want to introduce now, and Sarah's talk really kind of leads very nicely to our next presentation from Richard Kirwan, who's a nutritionist and PhD researcher at the Liverpool John Moores University. And in the course of the year, Richard's team published a really nice paper that I think pulled together very nicely, I think, what we were seeing certainly on the clinical front in respect of sarcopenia and the impact on muscle mass around COVID lockdown and restrictions. So Richie, I'll hand over to you, and
thanks very much, Siobhan, and thanks, Sarah, for a great presentation. And hopefully I'll be able to build on a lot of what you were speaking of there. So my name is Richie Kirwan. I'm a postgraduate researcher at Liverpool John Moores University, and my research focuses on the effects of body composition, but specifically muscle mass on cardiometabolic health, so heart disease and diabetes. So probably the reason I'm here today, again, is because of that paper that Siobhan mentioned, where we spoke about the possible effects of lockdown restrictions on people's levels of activity, on their eating habits, how that could affect muscle mass, and how that might affect their long-term health a little bit further down the line. And you can get a little bit more detail on that presentation, on that paper here, and you can get in touch with us via our social medias. Now, so I've got less than 10 minutes to absolutely fly through what is sarcopenia, what are the long-term health effects, why does it happen, and why it's relevant during COVID. So let's see what we can do. So why would muscle mass even matter? So sarcopenia is defined, it's the loss of muscle mass and function, or muscle strength, that happens as we get older. It's a perfectly natural process. But in some cases, it can be quite significant. So it can be up to 40% loss in some muscles in some individuals between the ages of 20 and 80 years. And that's a lot of muscle. Now, what's almost more significant than sarcopenia is something called dynapenia, which is something that's less spoken of. And that's the loss of muscle strength that happens as we get older and happens along with that loss of muscle, but it's probably more significant. And it might be actually more important than muscle size on a lot of long-term health conditions. And then there's also another condition called sarcopenic obesity, which is when somebody loses a lot of muscle mass, but they've got a lot of extra body fat as well. And the issue with sarcopenia is visually, it's not something that we're able to identify very easily. You can't look at somebody and say, okay, they're sarcopenic, and you can't weigh them and look at their BMI and say they're sarcopenic either. So it is quite difficult to diagnose in the clinical setting. We also know that there's something like a sarcopenic cycle. And in the sarcopenic cycle, what happens is we lose that muscle initially, we lose that little bit of strength, and that can lead to people having a little bit of difficulty with movement. And when it's difficult to move, their activity levels can drop. And when activity levels drop, we get a rise in fat tissue or fat mass. People gain a little bit of body fat. And that extra body fat on top of a lower level of muscle can make movement even more difficult, which again reduces activity. And we know that activity is a major player in why we lose muscle and strength anyway. So reducing that activity contributes more to muscle loss and strength loss over time. And we've got this terrible vicious cycle of sarcopenia. Again, why does it even matter? So we know that one of the major conditions associated with loss of muscle is cardiovascular disease. And actually, there's a condition, a concept called the obesity paradox, whereby people who are have a higher BMI in a cardiac population, they've actually got lower rates of mortality than people with lower BMIs, which is a bit confusing, but we think it's actually because these people have higher levels of muscle mass, which is cardioprotective. We also know that muscle loss is associated with diabetes, and that's because muscle is one of the most important insulin-sensitive organs in our body, used for glucose disposal whenever we eat. So lower muscle is often associated with diabetes, and also with osteoporosis, because our muscles play a major role in stimulating the development and the maintenance of our bone tissue as well. So the more muscle we have, or at least the more activity we do that can develop that muscle, the stronger our bones tend to be. It's also associated with frailty, and this is due to the muscle strength or the lack thereof, whereby people aren't able to do a lot of the daily activities that they normally would be because of this loss in strength. And there's also a greater risk of falls. And this happens because in sarcopenia, this loss of muscle, we lose a lot of the muscle fibers that we would normally use to rapidly react to losses of balance. So if somebody falls, they'd usually be able to react quickly if they've got the, if they're relatively strong. But when they lose that strength, they're not able to react as quickly to falling or slipping. They can't keep themselves from falling, so they're more likely to hit the ground. And as we mentioned earlier, because of osteoporosis, there's also a greater likelihood that they're going to suffer a fracture from that fall as well. And then there's also a link between sarcopenia and cognitive decline. And on top of that, based on everything that I've just said here, I think it should be kind of obvious that people who suffer from sarcopenia, they lose a significant quality of life due to not being able to take part in the normal activities that they would, perhaps not being able to go out and socialize. And that can contribute significantly to lower mood and potentially depression as well. So why does this even happen? And this is going to tie it into COVID a lot. Is one of the main reasons for muscle loss, and the primary reason is inactivity and not moving around as much as we usually do. Also, reduced energy and weight loss can contribute to that. And we do see that in some individuals during this pandemic, there has been changes in their level of energy intake, so their food intake, and some individuals have experienced weight loss. Other people have experienced weight gain as well, but it seems to be a very individual thing. Impaired sleep can contribute to muscle loss, as can chronic stress and anxiety. And anybody looking at this will know that all of these have been quite prevalent during the COVID pandemic in a lot of individuals. On top of that, more to do with just getting older, insulin resistance. So when our body isn't able to process glucose as easily, or doesn't react to the insulin stimulus to look after glucose, that can contribute to muscle loss, as can the chronic inflammation that happens as people get older, or when people gain a little bit of body fat. And anabolic resistance. So in older people, we know that the normal stimuli that we have for maintaining our muscle, that comes from protein, eating protein or doing exercise, it doesn't work quite as well in older people. So these are very, very much associated with aging, and these can contribute to that muscle loss. So just to kind of build on one of the main risks, the lack of activity, what does lack of activity actually do to our muscles? And there was a really interesting study that looked at just what happens if you make people walk around less. So basically, they got a group of people, older people, and what they did was they dropped their steps from 6,000 to about 1,500 steps daily. And a lot of people will look at this and say 6,000 steps, I'm probably getting less than that at the moment. And I know I certainly am from working from home at the moment. So this is a very, very real life scenario. And what they noticed after just 2 weeks is that there was a massive drop in insulin sensitivity. So people became very, very insulin sensitive from not being active. There was a massive drop in muscle protein synthesis, which is the process that we use for actually building and maintaining muscles. And at the end of that, there was a very, very significant drop in leg muscles. So just after 2 weeks, we saw like a 4% drop in leg muscle mass. And this is very similar to what would happen in bed rest if somebody's in an ICU. It would just be a bit more significant because people are moving even less. And it's a good example of what we call a catabolic crisis. So basically, older people, when they go into hospital, they'll often be very, very inactive for a number of days or a couple of weeks. And that can contribute to a significant loss of muscle mass really, really quickly. And we do know that these older people may not be able to regain that muscle as quickly as they would. And we see this continuous decline of muscle mass interspersed with these very, very rapid declines from being in hospital. So why does this matter during COVID? Well, we do know that anybody who's going to ICU, for example, and we do know that older individuals are more likely to suffer some of the stronger effects of COVID. They end up, we know that there's an average of about 12 days stay in a hospital if somebody's in ICU, which is a considerable amount of time lying down, not being able to be active. So that can contribute significantly to this loss of muscle as well. So we do know that because of COVID-19 in older patients, they're potentially more likely to spend time in hospital and to suffer some of the more negative effects of COVID. They're more likely to lose a loss of muscle and strength, and it's going to be harder for them to regain that lost muscle. So we're looking at this potential post-COVID rehabilitation crisis. And that's why this talk today is so important, that we get the opportunity to actually talk about what we can do to offset this in older people, to make sure that they're not losing muscle and they're not going to see any of those knock-on effects down the line. That is me. So thank you very, very much.
Thank you so much, Richie. That really sets the scene very, very nicely in terms of, I think, what a lot of clinicians, I think, especially, and indeed, I think people themselves on the ground have actually been seeing in respect of muscle change. I think the other, though, a very kind of optimistic thing to be optimistic about is that even with that change in sedentary activity that we have seen, we know that a lot of people have become very, very engaged in maintaining movement and maintaining activity at the same time. And I think it's really kind of heartening to see, I suppose, the interest that we see on the webinar today, and amongst others around how things are trying to kind of move in the direction of really preventing, I suppose, the deconditioning that we're talking about. I'm going to introduce next Dr. Sharon Kennelly. So Sharon is a clinical specialist dietitian in HSE services who's had a very keen interest in the management of malnutrition in the community for a number of years. And I know that she's been working particularly closely with us in older person services around, I suppose, trying to maintain, I suppose, key messages around the importance of maintaining nutrition, particularly in the course of pandemic, but over a much longer time as well. And is going to share, I suppose, some of the kind of key experiences and resources with us that will be available to you as you start to re-emerge.
Thank you, Siobhan, and welcome to everybody. Firstly, I'd just like to acknowledge the very important role that clinical nutrition support has had in the recovery of people with COVID-19 and their treatment, both in the acute and community settings. In the hospital setting, next slide please. In the hospital setting, many patients in ICU required enteral tube feeding and parenteral nutrition. And these and other nutrition support interventions were also required at ward level before and after ICU. Nutrition support is required in rehabilitation settings and in residential care facilities, as well as for people living in their own homes and recovering from COVID-19 and other illnesses. Existing nutritional care pathways were adapted and new multidisciplinary pathways were created, some almost overnight in healthcare settings during COVID-19. Dietitians and other healthcare professionals responded to the challenges in providing interventions, remote working and redeployment. Next slide, please. COVID-19 caused significant increased nutritional risk in nursing homes alongside other negative effects. In response, dietitians in the HSE, supported by the ICPOP and our MDT colleagues, developed a COVID-19 nutrition support pathway for nursing homes in May 2020. This pathway promoted a proactive treatment approach and acknowledged that normal practices such as malnutrition screening and the dining environment were seriously disrupted by the need for isolation and infection control practices. Now that we're moving to a post-COVID phase in nursing homes, from a nutritional care perspective, we want to see a return to the best practice in the dining experience for residents. The areas that we want to see improving are the return to routine malnutrition screening, our return to the normal dining room experience and the social enjoyment of mealtimes, and eliminating as far as possible the situation where residents were dining alone in their rooms. The return of visitors and daycare services is very welcome to nutritional care. A focus on assistance with eating and drinking and protected mealtimes are so important. Rehabilitation interventions should involve both optimal nutrition and physical exercise to be most effective. We have seen a significant increase in the prescription of oral nutritional supplements during COVID, which was necessary. But now we'd like to see a reduced reliance on these as a first-line approach and a return to a food-first approach to prevent and treat malnutrition risk. The recommencement of MDT nutrition teams in each site and return from redeployment of dietitians, speech and language therapists and OTs to support our nursing colleagues with nutritional care is also very important. We have heard earlier about the development of sarcopenia from Richie to reduce physical activity, cocooning and self-isolation. I'm going to focus here on another key contributor to the development of sarcopenia and frailty, which is malnutrition. Unfortunately, malnutrition is commonly seen in healthcare settings, especially in older people. We can see here from the malnutrition carousel that there's a deadly cycle that starts in the community prior to hospital admission, where 10% of older adults are at risk of developing malnutrition, increasing to 30% on admission to hospital. Malnourished people stay longer and they're more likely to be readmitted to hospital after discharge if it's not detected and treated with follow-up interventions. This graph shows us that increasing age, next slide please, is an independent risk factor for malnutrition, with a significant upward trend from 65 years of age. When our Irish Tilda data analysis, we found that there's several key determinants apart from age that can independently predict if you're going to develop malnutrition. These include having a hospital admission, difficulty walking and climbing stairs, a recent fall, difficulty cooking and shopping, having a single status and impaired cognition. So these are very aligned with the predictors of frailty. Next slide, please. This slide shows some findings from research that I'm involved in with the ONS Prez group, funded by the HRB, which is led by UCD. I'd like to share some of these findings with you now. In interviews with older people and healthcare professionals, the researchers focused on the term malnutrition. They wanted to look at people's views around the term and their understanding of it. The overarching theme identified is that malnutrition is a term to be avoided. This is broken into 3 sub-themes. The first sub-theme was that malnutrition is a term that people don't want to hear. Patients reported feeling frightened by the word and associated malnutrition with extreme scenarios. One person said, "I get very frightened. I just get frightened with that word, and I just don't like that word." Healthcare professionals, they thought that the term was to be avoided and it might be offensive to patients, and there was a blame associated with it. One GP said, "Malnourished people think that maybe it doesn't apply to them and they might be offended." The next theme was that malnutrition is a clinical term which patients don't understand. Healthcare professionals reported that they often used words that they deemed to be more favourable, such as lost weight or low in nutrients, when they explained the condition to patients. The final theme was the lack of confidence and ownership over the term malnutrition. Healthcare professionals who were not dietitians said they didn't feel sufficiently knowledgeable to bring up malnutrition with a person. One physiotherapist said, for example, I don't feel like I'm the expert. If I saw the dietitian that might say to them, I might say to them, but I wouldn't feel comfortable saying it myself. Next slide, please. These findings suggest that both healthcare professionals and older people and their caregivers themselves need to be better informed about the importance of good nutrition and the risks of developing malnutrition. In relation to what is good nutrition for older people, the FSAI have published updated scientific recommendations for older people in Ireland, with a significant emphasis on the prevention of frailty, which is very welcome. Key recommendations from this report include that healthy Irish older adults should eat a more protein-dense diet, foods such as meat, poultry, fish, dairy and eggs at least 2 meals per day. Older people need adequate calorie intake to prevent the development of malnutrition, frailty and muscle loss, and undernutrition, as we have just heard earlier. And a daily 15 microgram vitamin D supplement is now recommended by the Department of Health for all older adults in Ireland. The topic of nutrition and frailty is covered in the National Frailty Education Programme, which will be launched earlier. What is really important to know and understand is that we need both optimum exercise, nutrition and social engagement if we are to fully address the prevention and treatment of frailty. Next slide, please. So how can we identify malnutrition in healthcare and other settings? Well, the first step is that we use validated nutrition screening tools, and there's 4 broad situations in which these can be used. Firstly is when a person themselves or their caregiver indicates a concern about weight loss or unintentional weight loss or poor appetite. Also at first contact with services on admission to hospital or nursing homes, and annually in the community for older people, and repeated thereafter as required. Healthcare professionals suspect malnutrition when signs and symptoms are present, but we should be using validated screening tools. Finally, we should be using it as part of standardised assessments, including CGAs, falls risk assessments, and community nursing reviews. Next slide, please. To support the services, the National Nutrition Team have developed a tool online which can teach us how to use 4 of the most commonly and suitable nutrition screening tools for older people. You can access HSE Land to learn more about these modules, including the Determine tool, which can be self-administered by older people and their caregivers, and may encourage conversations with healthcare professionals around nutritional needs. Next slide. Nutrition screening is only the first step in nutrition care pathway. They're useful to promote the early identification of malnutrition and can help target interventions. However, screening tools are not diagnostic, and it's best practice that people who are identified at high risk of malnutrition by screening should be referred to dietitians for a full nutritional assessment and individualised treatment plan. Next slide. Keeping in mind recovery after COVID-19 and other illnesses, it's important to mention there needs to be a clear plan for not only medical care, but nutritional care following discharge from hospital into the community setting. GPs have often told us that they don't receive this information and they would value it greatly to help them direct care in the community. First and foremost, the patient and their caregiver needs to understand what recommendations have been made, but it's very important that the nutrition screening and care plan from hospital is communicated out to the GP for follow-up care. Next slide. We have created a number of supports to help not only healthcare professionals, but also people and their caregivers, and these are available at www.hse.ie/nutrition supports. There's practical support such as dietary advice leaflets and a high protein, high calorie cookbook called Making the Most of Every Bite. These are specifically for the treatment of malnutrition. And of huge importance is also the increase in real supports that's coming to the community, with the enhanced community care plan and significant investment in community dietitian posts as part of network and home first teams, as well as dietitian posts as part of ICPOC services. Next slide, please. Some other supports that are coming is an education module for GPs that we have also developed, and we're hoping to roll that out later this year, which will help GPs to start the first line identification and first line management of malnutrition. Next slide. We also have other nutrition training modules available on HSE land in the Discovery Zone. And finally, I'd just like to highlight the nutrition module of the National Frailty Education module, and acknowledgement to all colleagues who supported this, and thank you to Deirdre Lang for her leadership and forward thinking in including nutrition as a module in this. Thank you.
Thanks, Sharon, again. And I think, you know, a number of really valuable resources highlighted there in respect of the supports that we can put in place for people imminently. And I suppose highlighting things that were there prior to pandemic, but have only been exacerbated in the context of same. Look, I'm going to hand over at this stage to my colleague. Just actually before I do that, we have a second poll that we were going to ask the clinicians who are on the call if they would maybe partake in, and just really I suppose to look at, you know, in terms of what you're seeing in respect of these post-COVID rehabilitation needs and deconditioning in general as a result of cocooning, and, you know, any impact that you're already beginning to see in terms of your service or your practice. So we're just trying to quantify what it is that people, because anecdotally people are certainly telling us, and we're certainly seeing in our own practice, an acceleration of presentations in the context of people, we think mainly who have not been able to access services for a number of months. So we'd really like to hear that. I'm going to hand over to my colleague, Dr. Mike O'Connor. Mike is a consultant geriatrician in Cork University Hospital, and he has been recently appointed as the National Clinical Lead for Unscheduled Care for Older Persons, and he's going to guide you through the second part of this afternoon's sessions. Thank you, Mike.
Thank you very much, Yvonne, and thank you to all of you out there, 715 participants, which is really fantastic, and a treasure trove of presentations so far, and it goes on, and we have another hour to go. Siobhan mentioned at the start that we would have these presentations available as a resource, and that's a common question, the theme that's coming through. I'm delighted now to welcome Edel Brennan and Vanda Cummins, both physiotherapists, and clearly in a webinar which is entitled Time to Get Moving Again, it seems entirely appropriate that we would have physiotherapists giving a presentation. Both are giving a talk on how to start moving safely again after cocooning. Thank you.
Mike, we're just going to take a 2-minute comfort break before we meet Adele and Vanda.
Okay. Will I mention that to?
Here we go.
We're just going to take a 2-minute break, just to the participants, just before we welcome Edel and Vanda. A 2-minute comfort break. So it starts.
Back to you, Mike.
Okay, thank you very much again. 2 minutes is a very tight period for comfort break, but everybody racing for their comfort break for 120 seconds. So we're going to kick off again, as I said, with Edel and Vanda, both physiotherapists with the HSE, and the title of their talk is How to Start Moving Safely After Cocooning. Thank you.
Okay. Hi, everybody. Thank you for inviting Dell and myself to the talk today. We're delighted to be here. We both work in the community with older people, and it's wonderful at the moment to see with the vaccinations, people starting to come out and about again. However, unfortunately, some of them are struggling. Some of them are a little bit unsteady on their feet. They're feeling the effects of lockdown, and definitely they've lost fitness and mobility. So I think there's a lot of work to do, and I guess hopefully with this talk we'll share some ideas of how we can work together, and all community services work to really support these people. So first slide here is just about, you're probably all familiar with this, it's what we would hope older people would achieve, and it's having strength and balance at least twice a week to keep their bones and their muscles strong. They should be trying to do at least 150 minutes of moderate intensity activity, and minimizing sedentary time, so not sit for too long and up and about on their feet little and often as much as they can. Obviously, if we want to try and reduce any the risk of frailty, the risk of falls, sarcopenia, and obviously improve their bone health with this. So how do we do that? Well, we need to really ensure that we can get the right person. If we are offering physical activity and exercise programs, that we do get the right person into the right program at the right time in their life that they need it, with the right instructor. And the way to do that is we really need to measure, we need to know what their baselines is, and help them move from there. So this slide here just shows you some choices all of us have actually around movement, physical activity and exercise. And some people, there's a bit of, you know, what is physical activity versus exercise? And so hopefully this slide explains that. We're all in the business of moving. Even a very sedentary person, they have to move to get from A to B. Physical activity then helps you to achieve the things you want to do and be able to function, whether it's going up the stairs, getting up and down off the floor, all those things. So, you know, physical activity will keep you active and strong. And then exercise is actually structured and progressive. And with exercise, you're really trying to train to gain, you know, to build muscle bulk or to build strength or stamina. So you can see there's a difference, and movement and physical activity are part of exercise, but movement on its own is not necessarily exercise because it's not structured and progressive. So just so we think about where we all are, we're all on different functional trajectories. For a lot of older people, they're very active and they're doing very well. Some of them are in transition, what we call pre-frail. Nobody likes to be told they're frail. It's a term that older people don't like, but it's used a lot in medical world. And so we have people who are pre-frail, and we certainly want to help them to make sure that they can either improve or certainly not get into where they're actually frail. And if they're living with frailty, they're going to be struggling definitely with mobility, and they may be at risk of falls. So it's just useful to think of those different levels. Same when it comes to falls risk, we would grade people into a low risk of falls and what might suit them, into maybe some risk of falls, and then there would be older people who would be at high risk of falls. And then you can say, well, they need certain service for that. This is a nice slide here about so some research coming out of Newcastle University over in the UK, and it's called the life curve. And what they've done is they've mapped functional activities where you can see how well you're aging and if you're starting to functionally decline. And there's 15 activities, and they have looked at them and found that we actually decline in function in a particular order. So for instance, in that diagram, the first 4 things are pre the curve, if you like. So walking and getting up and down off the floor and all that, hiking up and down. But then once you start to lose the ability, like things like cutting your toenails, to not being able to have a full body wash, to maybe not being able to get out of a chair without using your armrests, you know, you can see you're gradually going down. And what we want to do with older people is keep them as high up on that curve as possible for as long as possible, so that when end of life comes, that they have a very short span with functional decline. So we really need some joined up thinking on how we help older people. I'm going to pass you over to Adele now. She's going to talk about some of the structures and frameworks that may help us to do that.
Thanks, Vanda. Okay, well, there's lots of evidence and best practice guidelines out there focusing on, community-based strength and balance programs and the importance of referral pathways from rehabilitation to community-based provision of programs for effective dose for prevention of falls and frailty. In particular, the Institute of Public Health have published an overview of guidelines, trends and policies on physical activity in the older adults. So it's all out there. Now, what the 5 key exercise recommendations suggests that we need to do is we need to raise awareness. So we do this through, developing marketing campaigns, tailor messages for the target audience, and make sessions appealing. We need to encourage uptake. So we need person-centered goals to increase motivation. We need to build relationships across the agencies. And, the exercise sessions, we need to have something for everyone. So exercise referral pathways that work. So these need to be developed collaboratively, and we need to provide good assessments for appropriate referrals. You need to stick to the evidence. We need person-centered assessment so you can tailor the program for the individual. And we also need to monitor for outcome and improvements. We need to identify tools for assessment and monitoring progress, and the use of digital tools suggested for monitoring progress and recording outcomes. So there's a lot of good things out there. Okay, we need to build on existing, current community exercise programs, and these have all gone on in the last year. So, the use of virtual delivery for online classes has really developed in the last year, and this allows us reach, a wider scope of audience to support engagement of exercise. I think this slide really shows, what we need to do. So the key to success is connecting community services together to help older adults live independently as they age. So now this is just a case study that both Band and I have already worked on, and it's an integrated project, and it was great success. It was a 26-week collaborative Otago strength and balance exercise program, and you can see on the slide all the agencies that were involved in the program. So as I said, it was 26 weeks. So the physiotherapists assessed the clients. They delivered the first 6 weeks of classes. And then the following 20 weeks were delivered by the fitness instructors. Now, the real success to the program was the joint training of the physiotherapists and the fitness instructors. This helped establish good trust and community links across the agencies. And it also enabled sharing of learning, of knowledge and expertise. So this slide shows that, it's not just all about the exercise. It's so important, things to make it effective. We need to motivate the clients, and the programs, they need to be consistent, and you need commitment, by all those involved. We need to educate the people why they're exercising. People need to know, why they're doing it. For example, it's going to help them get up out of the chair easier, or to be able to go back up the stairs, go back up to their bedroom. We need to get self-efficacy through conversations, and that is so important. And we need person-centered goals. So there's huge potential if we can get the pathways right for the different agencies nationally to collaborate together on shared goals and purpose of delivering, evidence-based programs. And as Vanda said, so this will ensure that the right person will get the right program at the right time for them with the right instructor. So now we're going to finish off with this slide. And as you can see, success doesn't always occur in a straight line. And as we both said, one size does not fit all. So we need to, build trust between the different agencies and have a two-way pathway so that someone can enter or exit a program based on their current level of need. We need fidelity to programs. We need to stick to the evidence. And exercise, it is as potent as a drug. And we need to continue to develop online platforms and apps to help support the person in their exercise. Thank you so much for listening.
Thank you very much, Adele and Vanda. A really pertinent presentation, and certainly something that we've seen over the last years in the acute hospitals is the increased frequency of falls and the presentations of our elderly population with falls because of the deconditioning. And that leads in nicely to our next speaker, And we're delighted to welcome Professor Roman Ortuno, who is Associate Professor of Medical Gerontology at Trinity and also Consultant Physician at St. James's Hospital. And he also chairs the Frailty and Resilience Working Group of the TILDA study. And we're delighted to welcome today to deliver his paper on putting the brakes on functional decline. Thanks, Roman.
Thank you very much. Good afternoon. My name is Roman Ortuno, and so I'm delighted to be talking to you today on putting the brakes on functional decline at this very important webinar that's focused on older persons impacted by COVID. This webinar is primarily focused on the needs of older people living in the community, but I will argue that the adverse effects of COVID-19 in the community may be of similar nature to those known to happen in the acute hospital setting, but of course at a different scale and magnitude. For example, in terms of hospital-associated functional decline, would you say that is it true or false that the majority of older patients who survive a hospital admission will regain their normal functional ability? Well, that is actually true. But however, approximately 30% of older patients may not recover completely and may develop new functional dependencies. A hospital-associated functional decline is always multifactorial and depends on patient-related factors at baseline that make them more vulnerable, for example, frailty, cognitive impairment, comorbidities, but also on how acutely ill patients are on admission. In addition, the outcome may also be influenced by how proactive and gerontologically attuned the hospital environment is to the specific needs of older people. In the acute hospital setting, the best evidence that we have to minimize the risk of hospital-associated functional decline is the provision as soon as possible of what we call comprehensive geriatric assessment, CGA, which has shown to make older patients more likely to survive the admission and be discharged to their own homes. Of course, in COVID-19 times, many older people living in the community will be robust and will be able to manage the effects of the pandemic quite well. But some others may have pre-existing vulnerabilities that make them more likely to decompensate and go under their usual functional baseline. So one might say that in the community, cocooning has to an extent been equivalent to not getting up, getting dressed, and getting moving whilst in the hospital. So the frailty model really also applies to the community where in many clients, COVID-19 and cocooning may have caused a new reduction in those functional abilities that needs to be rapidly and urgently addressed. Our Science Foundation Ireland funded Tropic Research Group, based in the Longitudinal Study on Aging, TILDA, has shown that during the pandemic, 15.6% of adults aged 50 and over experienced new feelings of exhaustion during the pandemic. It is important to note that in these same participants, feelings of exhaustion were not reported during wave 5 of the study, which took place prior to the pandemic. This study showed that participants reporting exhaustion were older with a mean age of 70, were more likely to be female and living with more chronic illnesses and physical limitations. In addition, TILDA participants with new exhaustion reported poorer emotional and mental health during the pandemic. In what we call a multiple regression model, we found that independent predictors of new self-reported exhaustion were the number of physical limitations prior to the pandemic, self-reported emotional and mental health during the pandemic, and interestingly, the experience of muscle or joint pain that is often linked to physical deconditioning and lack of physical activity. These results might suggest that the multidisciplinary rehabilitative approach with physical and psychological support, pain management, and multimorbidity control and interventions may help reduce the self-reported exhaustion that is of certain prevalence in the Irish population. So can things get better, or is it all doom and gloom? Well, things can indeed get better. Research from our other SFI-funded study called Frailmatics was analyzing the 5 tilde waves before the pandemic and modeled transitions of frailty phenotype states in all these tilde participants over 8 years, showing a real dynamic picture of transitions. Indeed, as shown in this slide, many people remain stable in their original frailty state over those 8 years of follow-up. In terms of the minority of participants who progressed over time to worse frailty states, there was a 27% probability of transitioning from non-frail to pre-frail between the waves. There was a 10% probability of going from pre-frail to frail, and a 2% probability of going from non-frail to frail. However, on the positive note, there were also frequent favorable transitions. There was a 32% probability of going from pre-frail to non-frail between waves, an 18% probability of going from frail to pre-frail, and a 6% probability of going from frail to non-frail. The results described this far refer to spontaneous observed transitions in the population based on the tilde data. But what do we know about how can we improve the probability of favorable frailty transitions into community? Well, there is evidence that in the community-based CGA, including attention to physical activity, nutrition optimization, health education, attention to the home environment, and social engagement, as you have already heard, can delay and even reverse frailty in community-based populations. And many of these interventions are rated as relatively easy to implement in the primary care context. So Tilda is currently studying the effects of the pandemic on frailty transitions, and preliminary data suggests the need for a renewed focus on the implementation of CGA in community and interface settings. With CGA being a multidimensional, multidisciplinary process that identifies medical, but also social and functional needs and develops an integrated and coordinated care plan to address those needs on an individual basis. So there is a need to embed CGA across the older person service model and integrate the various components of the networks, from living well with supports through community health networks and ambulatory care hubs to hospital care when required. And importantly, there is now good evidence that CGA in primary care in community-based settings can reduce the need for hospital care days in high-risk population of older adults. And of course, this could be of great importance in order to manage increasing prevalence of frailty and multimorbidity, especially now that we've gone through the pandemic. So what is the role of frailty identification within this model? As you know, frailty is not a medical diagnosis and is not a pretty word, as we've heard. But the identification of frailty in the community could help identify those who can benefit the most from community-based CGA. Indeed, CGA has been found effective only in certain subgroups of older patients, older adults, those that are not too well or not too irreversibly disabled. There's a soft spot for CGA. There's a general agreement that targeting CGA to patients most likely to benefit is crucial for the cost effectiveness of these programs, and also to make sure that these community-based programs are successful for individuals. So this is where frailty comes in. If implementing frailty identification in the community, we must think of the right tool that captures those who would be best benefiting from CGA in terms of identifying the remediable problems that will help delay and reverse that disabling process. The optimum frailty tool can be debated, and there are many available, But different tools will be suited for different purposes in different scenarios. And it is very important that when we think about the way frailty tools could add value to the equitable provision of CGA in the community, we develop robust frailty education programs, such as the National Frailty Education Program that's being launched today, as well as large-scale quality improvement and research initiatives and programs for the better translation of evidence into policy. There is therefore a need for a frailty network that links these important pillars. And this is why we need a critical mass of agents across settings and disciplines who would help put the brakes on functional decline in the community, and especially in older persons that are now impacted by COVID. Indeed, it is time to get moving. And I would like to thank Tilda and all its funders and collaborators, without which many of the insights that I shared with you today would have not been possible. Thank you.
Thank you, Roman, for a lovely presentation, really, which speaks to moving evidence to policy, as you said. And in addition to that, again, along the theme of other speakers, is actually connecting the various agencies, because a lot of this is not complicated. A lot of it is common sense, doing the simple things correctly every time. So thank you very much, Roman. So we'll move to our next speaker. Our next speaker will be known to many of you as an absolute champion of orthopedics and fragility fractures. That's Louise Brent. She is currently the audit manager. She's the manager of the Irish Hip Fracture Database and the major trauma audit manager with the National Office of Clinical Audit. In addition to that, her background is orthopedic nursing. She's published on many topics around falls and fragility fractures, and indeed has been significantly involved in the Frailty Network also. So we're delighted to welcome Louise, who's going to deliver a talk today on preventing falls at home, common causes and triggers. Thank you, Louise.
Thank you very much, and I'm absolutely delighted to be here today. We've heard some excellent talks already, and I'm hoping I can impress upon all of you some safety messages that we can all take away today. As Mike mentioned, I manage the Irish Hip Fracture Database and the major trauma audit for the National Office of Clinical Audit, and both of these audits focus on the more severe end of trauma. So hip fractures occur typically in our older population, people over the age of 80, and major trauma can be defined as accidents that cause life-threatening or life-changing injuries. I'm also presenting on behalf of my clinical colleagues, Dr. Emer Ahern, Mr. Conor Herson and Professor Conor Deasy, who help lead these audits. So just to set the context, first of all, in Ireland each year we have about 3,700 hip fractures presenting to our hospitals, and nearly 6,000 patients suffer major trauma. So it's a huge, huge workload for the health service. But the future is bright. In 2018, the Department of Health published this wonderful report which sets a precedent for how our trauma system of the future will be built. And it defines the new trauma system as 2 trauma networks, one for the south of Ireland and one for the central northern part of Ireland. And we'll have a major trauma centre in each of those, and then a number of trauma units focused around each major trauma centre. And the idea of this is that patients can be brought to the right hospital to deal with their injuries at the right time, and not just whichever hospital is closest to them. Within this report, there were many, many recommendations, and I'm pleased to say lots of these recommendations were focused on the prevention of trauma in the first place. So I'll come to that as we go through the presentation. This is what our bespoke trauma system of the future will look like. We have our patient having an accident, and the ambulance personnel or the pre-hospital carers being able to decide based on their injuries which hospital would be able to care for them the best. So they can either be brought directly to a major trauma centre, a trauma unit, or a local injury unit. And depending on where they're brought, the right team will be there to meet them and deal with their injuries. And then, all things going well, the patient gets the right care they need, rehabilitation and support so they can come back home. But I'd like to pose the question about what if we could remove this first step altogether? I know I'd be doing myself out of a job, but actually from much of the data we have in both of the audits I manage, we can see that a large portion of the traumas are actually preventable. So for example, the Irish Hip Fracture Report has shown consistently that 95% of hip fractures are caused by low falls at home. That's a simple fall from standing height or less. And almost 1/3 of our hip fracture patients have already presented themselves to our hospitals in the past, having had a fall and a previous fracture. So they've told us they're coming. And when we look at where these falls are happening, almost 95% of them are happening where patients live. So 85% are in their own home and 10% are in long-term care facilities. In the major trauma audit, we see that nearly 2/3 of major traumas are caused by low falls again, and almost half of them are happening in the home. And yet, we've all been told to stay safe and stay home. But I'd like to change that mantra a little bit. We absolutely have to stay safe and stay home in terms of the pandemic, but we can also stay safe at home as well. Throughout the pandemic, we can see that the numbers of traumas presenting to our hospitals hasn't changed very much. So we're still getting lots of people in, having had lots of accidents. And we know from early data from the hip fracture database that patients who have a hip fracture and a COVID diagnosis have much worse outcomes than those that don't. So we need to do everything we can to stay safe at home as well. And 2 years ago, we did a deep dive into the data in the major trauma audit to really try to fully understand what people were doing in their homes that was leading to so many falls and accidents. And what we noticed was lots of people were falling over in their bedroom due to balance and gait disturbances. So if you feel unsteady, the simple thing is sit down, take your time getting dressed and do it in a seated position if you can. In the kitchen, there was lots of people slipping on wet floors, and I've done it myself. I've taken the risk after I've mopped the floor to go back in and grab something off the counter. It's not worth the risk. There are too many people who can tell you they've hurt themselves significantly from doing that. Another one, again, that I'm probably guilty of myself, but I know my mother does this a lot. She puts things that she uses regularly up on the highest shelf she can possibly find in the kitchen, even though she's only 5 foot. So it's about being really sensible and making the right choices and putting things where you can easily reach them so you don't have to climb up on chairs and stools to get them. Steps and stairs was another big area for falls. So paying attention when you're going up and down a stairs, try to have your hands free, not carrying too much stuff, not texting. And if people do have mobility issues, really consider putting in a second banisters on the other side. Pets are, a small contributor to the overall number of traumas we see, but they do still contribute quite significantly. And I almost fell over my own cat yesterday, so I'm going out this weekend to get a little bell for her collar because she was under my feet before I knew it. Making sure that our floors are safe as we walk across them. So if you're completely committed to having rugs and such in your house, make sure they're secure so you can't catch your toe on the edge of them. Similarly in the gardens, and I know many of us have been making much more use out of our gardens now as we're all at home so much, but just to make sure that the walkways and the paths are clear, free of moss, not too slippy. And finally, in the bathroom, again, if you're getting in now, the shower, put your mats down, all very sensible things, but I can tell you from the data we see every year, there are hundreds and thousands of people falling and hurting themselves as a consequence of not doing these things. Making sure there's no ropes or loose cords where you can catch your feet as you walk around your house, and lighting. If you have to get up in the night to go to the bathroom, for example, either give yourself a chance for your eyes to adjust to the light after you flick it on before you get up and make your way, or leave a light on in the nighttime, because we see lots of people falling over in the dark and hurting themselves very significantly. So if I can impress upon it, all of you today, these safety messages are not just for older people, they're for all of us. Falls are the leading cause of trauma in all age groups across both the audits that I manage. If we can all go home with a fresh pair of eyes tonight and just look around our own homes to make sure they're as safe as possible. We all go and get our cars NCT'd every year to make sure they're roadworthy. We should pay the same attention in our own homes, especially now that we're spending so much time in our homes. And the consequences, if we don't do this, are dire for some groups of patients in particular. We know that our older patients, they are much less likely to return home and much more likely to have serious disability and die as a consequence of their injuries. So it's our responsibility to look after ourselves and keep our homes as safe as possible for all our families. So thank you very much.
Thank you, Louise, for a crystal clear presentation, really, with practical messages for all of us and also practical messages for our patients. And again, it comes down to the simple things done well, really, to be honest. So we move from one absolute champion to another champion, Deirdre Lang, who again will be known to many of you, who really has devoted so much of her time working the acute services, has moved in many grades of nursing, including Director of Nursing in the HSE. Currently, as you know, Deirdre has been a champion of frailty. She's going to be joined today by Geraldine Shaw, and the purpose of today, a lot of today really, to be honest, is actually around frailty and the launch of the National Frailty Education Programme. We're delighted to welcome Deirdre and Geraldine, and the floor is yours, Deirdre.
Thank you, Mike. I am so excited to be here today to be finally launching the National Frailty Education e-learning programme. Just to give you a bit of background, and you all know this, but the prevalence of frailty in community dwelling older adults in Ireland is quite significant, with 17% up in Donegal, up to 28.5% over in the east of the country. Frailty, it's a long-term condition, and it shares the features of typical long-term conditions in that it's common, it's costly at the individual and societal level, typically progressive but not always, potentially modifiable, and people often present in episodic crisis. If we consider frailty as a long-term condition, we then begin to apply internationally established models and implement evidence-based care. What we know, the recognition of frailty is important and should form part of any interaction between an older person and a health professional. And an individual's degree of frailty is not static. It may be made better or worse, depending on the care received when the individual presents to their health professional. We know that by increasing the understanding of frailty, we can improve the detection, prevention, management, and therefore outcomes for older adults. The National Frailty Education Programme has partnered with the Acute Medicine and Emergency Medicine Programme, has been funded and supported by the Office of Nursing and Midwifery Services Director, Geraldine Shaw, and is a collaboration with TILDA. TILDA, as you heard from Roman, is the Irish Longitudinal Study on Ageing, and it aims to make Ireland the best place in the world to grow old. It has 8,504 participants over 50 who participate in its research waves, and that represents 1 in 156 adults over 50 in Ireland. It is hugely representative of our population. And this allows the collaboration that facilitates the translation of research into practice. The programme steps to date have been that we have worked with facilitators in cohorts that have gone to TILDA from hospital groups and community health organisations, and they've attended Mary O'Shea's Insight into Frailty, a bespoke one-day education programme. They then came to a network event with myself and my colleague Carmel Hoey, where we did a workshop on how they were going to scope out the local implementation of the education programme, and then they began to roll it out in September 2017. And here's some of the facilitators attending TILDA. To date, 397 healthcare professionals have attended that one-day insight into frailty and have then become frailty facilitators. Our national frailty facilitators are a group of people I am so proud of because they have done amazing work. These are people who have a memorandum of understanding with their line manager that facilitates them to be released to deliver the programme. They've completed that one-day education programme with TILDA. They've attended the workshop, they're a member of the Frailty Facilitator Network, and they're entered on our Frailty database. There's 27 of those networks nationally, 379 facilitators, and they have delivered the programme to 3,549 people since 2017. Never mind that we've had the pandemic in between. And the evaluations of the programme have been really, really good, a 4.82 out of 5. So it's been really well received. It's also been really well received internationally, and the Joint Action Group from Frailty recognises it as one of the key enablers for building workforce capacity. And it's also been cited as translating research into practice in the Journal of Aging and Social Policy. The programme contains these modules: frailty, CGA, bone health, nutrition, delirium, polypharmacy and frailty, continence and cognition. It's been designed by experts, and here's some of them here, signed off by the Clinical Advisory Group, which is really important because that they have given its credibility. It will now be accessed via HSE land from today, and it gives 20 CEU points from NMBI and 1 CPD point per hour for other professions. The classroom version is being revised by experts. It will form part of a blended approach to education. So we would ask anybody who does the online programme to complete the evaluations to assist us to inform what will be the blended programme. And this is the broad breadth of the facilitators around the country. So you can see that we do have excellent representation in each of the areas. I'm going to hand you over to Geraldine Shaw, Dr. Geraldine Shaw now, who's the Director of the Nursing and Midwifery Services and the Assistant National Director in the Office of Nursing and Midwifery Services. Thank you, Geraldine.
Lovely. Thank you, Deirdre, and good afternoon to all the attendees. I am delighted today to launch the e-learning National Frailty Education Programme, which has been a work stream that has been supported by the ONMSD since 2017. I know from Deirdre and her ongoing reports to me that the programme has been evaluated very positively, and there has been lots of evidence of influence to a positive nature of the programme on the ground. Improving the quality of care delivered to older people is all of our business. And therefore, we're delighted that this programme is now going to be available on an interprofessional and integrated learning platform. So that's really useful. Before we officially launch the programme, I want to thank a few people. Deirdre, I think, is going to do some slides from there. So we're going to start off with those that had the vision, and you're looking at some of them there on your slide. Dr. Diarmuid O'Shea, from my own office, Deirdre Lang, who has just spoken, and Carmel Hoey, they've been really, really good in supporting all of this. And Helen Whitty, who's also there as well, Programme Manager for the clinical programme for older persons. So without their vision and innovation at the outset, none of us would really be here today. I remember Diarmuid saying to me back in 2018 when they started that, you know, over the next couple of years, if we had got 500 healthcare professionals through, that would have been considered a success. And as Deirdre has just outlined to you there, at the minute, we've got over 3,500 that have successfully come through the programme. I would also like to thank Dr. Colm Henry, Chief Clinical Officer in the HSE, who's in your photo there, along with Dr. Siobhan Kennelly, National Clinical Advisor Group Lead. And they, at a senior level, have been strategic sponsors of the programme and have endorsed and supported it along the way. So the endorsement at this senior level has been really important because that has actually helped with the release and support of staff to attend this on the ground. It's really, really important. The next two slides, which Deirdre is going to flick through for me, that these show the 8 modules that have been developed as part of this programme, and they have been put together by groups of subject experts. You'll see on the 2 slides that the list of those that have been involved with them are written in beside the particular modules. So the modules are polypharmacy, continence, cognition, comprehensive geriatric assessment, and Deirdre's going to flick the slides to me, nutrition, delirium, mobility and bone health, and frailty. And all of those people that are listed down there, in the interest of time, I won't go through saying everybody's name, but just to say that this would not have come about was it not for these people giving of their time and expertise and contributing to make this happen. So thank you very much for that. I've got a few more thanks to say, and particularly in relation to the Clinical Advisory Group of the National Clinical Programme for Older Persons, who reviewed and signed off on the content and have supported the programme since its conception. The longitudinal study on ageing, in particular Miss Mary O'Shea, whose vision and support has been key to the programme. Professor Roseanne Kenny, primary investigator Tilda, and the Tilda team, which comprises of Orna Donoghue, Christine McGarrigle, Aisling O'Halloran, Siobhan Scarlett. The National Integrated Programme for Older Persons, you've heard from Dr. Siobhan Kennelly, the National Clinical Advisor and Group Lead earlier on today. PJ Hartnett, who I know is online there, is Programme Manager. Des Mulligan, who's also online. Jennifer Hardiman, Marion Mulvaney, Service Improvement Managers. Dee Connery, the Change Manager. Alison Cronin, Executive Assistant to Siobhan Kennelly, who we know that these kind of days and events don't come about if it's not for that executive admin support. And from the Orium Information Technology team, especially Mark Jordan, Neha Baj and team. I'm going to go to the next slide, Deirdre. These pictures are pictures of the facilitators receiving their certificates back in 2018 at the Framing Frailty Conference. And it's really important to stress that without the facilitators, we would not actually have been able to deliver on this. So an extreme thank you to all of the facilitators, lots of them who I'm sure are online today. So this would not have been able to happen without you. And it's great now that there has been over 3,500 people trained nationally. So in conclusion, today, it is my absolute pleasure to have supported, to continue to support and to launch the National Frailty e-learning programme, which is available on HSE Land. That's www.hseland.ie, and it is available to all. I would like to hand you over now to Dr. Colin Henry, Chief Clinical Officer of the HSE, who is standing by, I do believe, to say a few words to close the event.
Hi, thanks. And I've just been listening in for the past hour, and thank you to all the presenters. I just want to say a few words to close this, if that's okay. And it's good to be among friends in a gathering like this. I deal with a whole spectrum of friends, but there's no closer bunch of friends than people who deal with frailty and with older people. It has been a tough year for frail people, and it's been a tough year for frailty, without a doubt. And this virus has had a horrendous impact. We heard from Naomi McConnell on the impact it's had on older people. We know too, and we know from work of many of you have done in bringing this to our attention, the secondary harm that's resulted for older people in terms of isolation, in terms of what was asked of them in order to avoid contracting a virus, which in particular had a particular virulence among this population. And we know as well from our frontline staff and from people like yourselves what the impact of isolation has, what it's had on people, not just in terms of delayed presentation of illness, but in terms of psychological harm, in terms of the isolation, as I said, that have suffered throughout the past 14 months. But there is huge hope ahead, and we're now at the cusp, as we know, of a new set of national guidelines, which it pulls us all outdoors and encourages us all to enjoy the summer, albeit not in the same way as previous summers, but particularly asks for older people and gives guidance to older people that puts them in a par with middle-aged and younger people for the first time in this pandemic, and that's hugely welcome. And if you look at what's been achieved in terms of vaccinations, beyond what we could have hoped for. There's been over 700,000 vaccinations given to over 70-year-olds. We finished in the most difficult circumstances and in the most frail of populations in January. We provided vaccination to a very willing population. Over 105,000 people received both vaccinations in nursing home settings, 580 nursing homes, many of them in the middle of an outbreak. And the results, as I said, are beyond what we could have hoped for. If cases over 75, that's say COVID cases over 75, there were 6,700 in week 2 of this year. There were 212 last week. Outbreaks in nursing homes, there were 30 in 1 week in January. We've had 1 the past 3 weeks. And the outbreaks we're seeing now have much fewer number of cases associated with them. Those hospitalized over 65 years of age, we saw 2,747 in the first 4 weeks of January. We saw 138 in the past 4 weeks. And these changes, this improvement is, we know now for the first time we see a fracture between the numbers of cases we see reported every day, because they're still quite high at 400, 450 per day, but a fracture between that and a disconnect between that and the harm that's done among vaccinated populations. At the same time, we're seeing, as we creep back out into the daylight, we encourage other people to do so. We see our hospital service do likewise. Our EDs and activity in our emergency departments, activity and attendances and admissions of over 75s to our emergency departments are now not just way above what they were like last year, where everything was shut down this time last year, but they're now in a par, or if not higher than what they were like in 2019. And yet we see thankfully reduced scenes that we usually associate with those numbers coming to emergency departments, in terms of much lower number of trolleys, much shorter patient experience times. And much of that, where that comes from, is from the advocacy of yourselves, of clinical leaders who are among the group here today, from all different disciplines, who knew what the right thing to do was in terms of creating alternatives for older people, of pushing care back into the community, of left shifting care for older people, and ensuring that there wasn't a default situation where older people had to come to emergency departments, wait for long periods of time, and then wait even longer periods of time before their deteriorating condition was addressed once they came into hospital. And it's that advocacy and that design from many of you here that led to the investments we sought and succeeded in getting in the Winter Plan and the National Service Plan, and which I believe are making real changes. I just want to, in terms of this, it's great to be in a position launching this National Frailty Education Programme. It's clear here from people today the impact, as I said, of frailty through the spectrum and through the prism of COVID-19 has been quite substantial. And the really wonderful thing about this piece of work is it gives it a profile, and the profile it needs among healthcare professionals. Mike and I were discussing a book we saw published recently by a healthcare professional, where it was stated in the book that that disciplines associated with care of the elderly enjoyed a much lower profile, a much lower level of, if you like, respect and value than those where clinicians might opt to work in labs or with scopes or with procedures. And it's precisely this attitude that it becomes a self-fulfilling prophecy. If people are told that it is not of value and it is not a substance to deal with complicated issues with people who are frail, who have multiple conditions, to see their illness not beyond the needs that can be addressed in a lab or through a procedure, but through a multidisciplinary working through that difficult, painstaking effort of seeing their illness through the prism of their own social background, their own isolation, their own function capabilities or not. It's certainly, we all know it, the easier route to pursue, the easier road to pursue in medicine, nursing or otherwise, is to go down a route where you only have to answer one question and not multiple questions at the same time. So that this work is important, is it gives its own dignity and profile to work that absolutely deserves that the highest dignity and highest profile in our healthcare services, and not to be derided in some way as if it's some kind of inferior work that shouldn't be valued by healthcare professionals. Healthcare in Ireland, of course, I'm fortunate in that I trained under mentors who instilled and conditioned me to think that way. And there were Michael Hyland, Killian Toomey in Cork. And I know there's many great departments elsewhere carrying on that tradition of professionalism, but advocacy at the same time. And this is a key enabler to building workforce capacity it's been recognized by the EU Joint Action on Ageing. I note that this recognized use of collaboration with TILDA as an innovative way of translating longitudinal research to practice is something, again, we're leading on. And I'd like to acknowledge the huge work of TILDA and the kicks up the behind I receive from them regularly in terms of the support they need from the HSE. We had a great seminar in Dublin Castle in 2018, I remember, to thank the National Frailty Facilitators for their commitment to the programme. And as we meet again now, albeit virtually, I would like to thank them for their evangelism and their professionalism and their commitment, which is truly vocational to this programme. It's not the easy route to follow in professional practice, but it's the right one. And Milton Freeman said once that one man with a correct opinion outweighs the majority. And we're dealing with many people in this call today, all who, in my opinion, have the correct opinion, which outweighs the majority. 3,200 plus healthcare professionals done through a classroom program is phenomenal in such a short time, and I'd like to pay tribute and acknowledge the work of all the facilitators in achieving this. I know from speaking with Deirdre Lang and other healthcare professionals who leverage this program, of the amount of hours, the dedication, the commitment gone into the content and reviewing the storyboards, and I'm really proud to have these people working with me as colleagues in the HSE. I finally would like to thank Geraldine Shaw, a colleague of mine in the HSE Central, for her support of this programme and having the foresight to fund it when it was most needed. And also like to acknowledge a towering giant in geriatric medicine, although she's too young to have that, and that's of course Siobhan Kennelly, who's leaving shortly as our National Clinical Advisor for older people. This is the second time she told me she's leaving, but I believe her, but I know she'll be back in what form. I don't know. Her talent is too great in terms of her belief. It's not just her vocation. You can see the authenticity in how she's pushed for funding, how she's pushed for models of care, and how she's driven through, and also how she's represented ourselves and our work with older people in sometimes really difficult circumstances in the past year, when we had to slog through days in the dial, holding ourselves to account for why the plane was careering on with almost all engines down, but having to fly the plane at the same time. So thank you, Siobhan. Also want to acknowledge collaboration between older people, emergency medicine and acute medicine programs, and welcome Mike on board at his new capacity. Dermot O'Shea, another great support here in that day in Dublin Castle. I was really moved by Dermot's commitment on that day. What was a personally very difficult day for him, but one that showed he came out and was part of the award ceremony and part of the encouragement, and thanks to all our healthcare staff. Other people, Deirdre Lang, Carmel Hoey, Helen Whitty, and everybody who's Roseanne Kenny, anybody who's a part of this great movement that is that involves not just care of older people, but care of frailty. It's the work is long lasting. It will have a huge legacy, and you deserve the thanks and acknowledgement of everybody in the HSE and of society at large. So míle buíochas samúid illig frí cumíníomh illig agus tardini éistear for the hair for cumíníomh foster. Thank you.
Thank you very much, Colm, for those very kind words. I thank all of the participants. We look forward to a day where we're all in the same room together. I thought the talks were just aimed with obviously the situation we're in now, that we don't have that post-meeting excitement and sharing of experiences, but that's going to come around again. That's going to come around again, and I very much look forward to it. We've held the number of participants that have joined this meeting from the start. Often you get in meetings, people fall away, but in fact, there is a group of people who've just stayed on. And I think it might be appropriate maybe to give the last word to Siobhan Kennelly, really, and to echo Colm's thanks to her for the commitment and utter commitment and drive that she's shown in her current job. She'd be sorely missed. So over to you, Siobhan.
Thanks, Mike, and thanks for the very kind words. I want to reiterate, I think, sincere thanks to obviously our attendees today, but really sincere thanks to our speakers, who were just, phenomenal really in terms of what was organised at very, very last minute, including Colm, I think, who has been just an absolute stalwart in terms of not just older people, but actually the clinical management of health services in general, and being such a great voice, I think, for patients everywhere. Finally, I really want to give sincere thanks to the phenomenal backroom team actually that have actually really pulled this together again at very short notice. So Leo and his team in IMS, but particular thanks to Alison and Helen and Des and others who really helped, I think, really pull together the programme, made sure that we all stayed on track. These things just do not happen on their own. So really, really sincere thanks. And I really am looking forward to an IGS, however we make it happen, Roman, Diarmuid, Roseanne and others, where we actually all can, I think, celebrate the huge, I suppose, drive in terms of knowledge. And as you said, Mike, so aptly linking evidence to policy and to service development. And, I think we're really in such a positive space about that now. It's such a positive day. Like I said, compared the newspaper headlines today to this day last year, we're moving into a great space. And I think we have so much to look forward to. So I wish you all well, and sincere hope that we will all meet each other again in person soon.